Good afternoon, and welcome to today's caregiver webinar, Caregiving for Loved Ones with Parkinson's. My name is Katherine Hall, and I am the Social Services Specialist in the Caregiver and Support Services Unit with the Fairfax Area Agency on Aging. Just a few housekeeping items before we begin today's session. Today's presentation is being recorded. A link for the recording of the session and slides will be sent to all of you by next week. We have enabled closed captioning, and you can turn the captioning on or off at the bottom of your Zoom panel. If you have any questions during today's presentation, please use the Q&A button, and we will try to get through as many questions as possible at the end of the presentation. There will also be a quick survey as you sign out. If you can please take a moment to answer those questions, it helps create programs that are relevant and interesting to our caregiving community. Now I would like to introduce to you our speaker, Dr. Mick Reedy. Dr. Reedy is a specialized care physician, board certified in neurology, and a fellowship-trained movement disorder specialist at Inova Health System. He joined Inova in 2023 and has been practicing since 2018. Prior to joining Inova, Dr. Reedy was a movement disorder fellow at the University of California. Dr. Reedy specializes in management of Parkinson's disease, essential tremor, dystonia, ataxia, tic disorders, Huntington's disease, and other movement disorders. He has specialized in the use of Botox toxin injections and deep brain stimulation for movement disorders. Dr. Reedy pursued a medical career in neurology after discovering the neurosciences while attending Macalester College in St. Paul, Minnesota. He later became interested in movement disorders given their inherent complexity coupled with meaningful pharmacologic and technologic interventions. Dr. Reedy strives to ensure patients and their loved ones feel empowered to the best to manage their disease, and his goal is to work with each patient to improve their quality of life. Dr. Reedy currently resides in Washington, D.C. with his significant other. He enjoys playing guitar and enjoying jazz, comedy, science fiction, and Chicago sports. Dr. Reedy, please join us on camera and take it away.
Good morning, everybody. Hopefully you guys can hear me okay. Yes, I enjoy Chicago sports, but maybe not this year, just in case anybody's actually watching Chicago sports. I talk very fast. I do apologize. That's the good reason why this is being recorded. That'll help. But part of that is I have a lot to say, and 60 minutes doesn't always cover just how much I want to talk about. So we're going to try to save some time at the end for questions, which I think will be important. So if I do rush through some of the stuff, I apologize. Certainly ask some follow-up questions. But part of it is I am just sort of reading slides for the most part. I'm not often going to add stuff that's not already written down, or at least is what's not really super important. So certainly ask questions. I'm going to try to get through this so that it can be done about an hour or so. And then we should be able to save some time so that we can honor your guys' time as well. But spend an additional 10 minutes or so just answering questions, make sure everything is covered appropriately here. So I'm going to give a talk on Parkinson's disease. This is sort of caregiver focused, just to kind of help the caregivers get a sense of what to expect with Parkinson's. There's a couple objectives that we're going to try to get through. The first of which is just largely about education about what is Parkinson's, what would you expect as far as symptoms, and how much you expect it to change over time. The second, we're going to talk about different techniques that can be helpful for Parkinson's symptoms. And those techniques will be related to medications, potential surgeries, and procedures. But additionally, from behavioral things, just what is the sort of conservative stuff you can do to be helpful. And the last topic will be a sort of expectation on how might things change over time and what kind of adaptations can caregivers and even patients themselves do to help kind of adapt accordingly as things change. And so this talk is not on what is Parkinson's disease, but you can't talk about Parkinson's disease without trying to explain it a little bit. And so Parkinson's disease is it's a progressive neurodegenerative disorder. And what that means is that it's something that gets worse with time and it seems to affect the nervous system. So that's the neurodegenerative component of that. And primarily what we see it affecting is movement, but it does other things as well that are pretty complicated. And we'll talk about that as we go. Very simply put, it seems to be a deficiency in these neurons, these cell bodies in the brain that create a chemical called dopamine. Dopamine is a neurotransmitter and it's used to do a lot of things. But what I like to think of it, just to simplify it, is it acts like your body's battery. And so it helps people initiate movements, sustain movements, hold postures, but it does more than that quite clearly. And anybody with Parkinson's or loved ones with Parkinson's knows that Parkinson's is way more than just, okay, I'm a little bit slow and stiff. There are other things that come along with that too. So the bad news is it's exceedingly common. And so it's 1%, 1 to 2% of people over the age of 60. It seems to be about 1 million Americans or so. And it seems like the incidence of it is increasing from year to year, or whether or not we just have better ability to diagnose it kind of remains unknown. But it seems like it's increasing every year too. And it's enough that we see 90,000 cases a year, enough to fill up the Rose Bowl. We generally think of it, if we look at the bottom right, is that the top is sort of the quote unquote normal neuron. And you can see all these little blue dots are the dopamine or the battery. The Parkinson's neuron does not release quite as much of that battery to that receptor there. So we think of it like kind of being in a low battery state, kind of like a low gas state in a car as well. So there's a couple of risk factors to be aware of. Certainly genetics is a part of it, but not much. Only really 5 to 15% of people or so we consider to be really genetic. Genetic in the sense that gender, or actually I should really say sex, actually plays a very clear role. It is more likely to affect men. Environment seems to play a role as well, maybe even larger than genetics, though those are certainly together. But pesticide exposures, herbicides, especially things like Agent Orange, exposure to air pollution, so living in a city, well water, so affecting people even in rural areas, heavy metals, solvents, things that cleaning supplies, other toxic things. Anything that you think, yeah, that sounds kind of toxic. Well, yeah, they are. It is toxic, and our bodies don't really like them, actually. There are some lifestyle factors as well that may play a role. So some protective things, yes, exercising regularly. Weirdly enough, caffeine has been shown to have some benefit, but there's always trade-offs with caffeine. The Mediterranean diet seems to be helpful as far as preventing things, as well as smoking, but smoking has many other consequences that do not make it worth doing in the long run by any means. There's some harmful things too that maybe make people more likely to get Parkinson's. So head injuries, poor diet, the American diet, basically, stationary lifestyle. So basically, the things that you think are healthy for you, things that people are taught are healthy for you, yeah, that turns out that is really healthy for you, and it does help, and it seems to help decrease people's risk of getting Parkinson's disease. Probably the largest factor here is age. It tends to be something people get with age. And the most common Parkinson's disease demographic would be a 70-year-old man, basically. But it affects people at all ages. And I personally know people who are in their 20s with Parkinson's disease. So it doesn't need to be an old person's disease by any means. It certainly affects young people. There are a bunch of symptoms that we think about with Parkinson's disease, and we'll go through the kind of major ones for the most part. It can be a little complicated to divide the motor versus the non-motor symptom, and we'll kind of explain it as we go. But I've tried to categorize it this way. Bradykinesia means slowness of movement. So brady is like less than, and kinesis, less than movement, less movement overall. So people with Parkinson's have to have bradykinesia for the diagnosis, actually. It means that the movements don't move as well. They're not as fast. They don't sustain as long. Maybe people don't blink as often. They don't gesture as often as they used to, kind of numerous things. Muscle stiffness, which is also called rigidity. That's not something typically people can necessarily feel. It's more so something that the physician feels. Though sometimes people say, yeah, I got this frozen shoulder, those types of things. So occasionally it can manifest kind of early. People will get resting tremors. So if they sit there, they might kind of shake it from time to time. Apparently that can be up to 70% of people over the course of their Parkinson's disease may notice a resting tremor. That's pretty variable though. And sometimes people will have some troubles with their gait and their balance. So just walking, kind of scuffle. You can hear them from the other room, kind of scuffing the floor. Occasionally people's feet will get stuck to the floor. That varies from person to person. Speech can be a little bit quiet as well. And sometimes people have a little bit of difficulty swallowing. These are all very unique things, but oftentimes speech is affected. People will say, oh yeah, people have been telling me to speak up, and it's been going on the last couple of years or so. That can be a really early symptom. Some of the non-motor symptoms would be things like loss of smell. That's exceedingly common. Decreased appetite, which can come along with that. If stuff doesn't smell as good, most of our taste actually is smell. So people might not eat as much. Autonomic nervous system issues. That's things like constipation, bladder issues, low blood pressure. Some people will get some changes with their thinking and their memory, be a little bit less attentive, and some people become depressed, anxious, or just get panic attacks. Sleep is commonly affected as well. But what is Parkinsonism? And so you might hear this term just when you're seeing other doctors, depending on what your diagnosis and your journey through Parkinson's disease. But Parkinsonism is just a description; it's the adjective of the disease. So instead of Parkinson's disease, we say someone has Parkinsonism. And so it's a way of saying people have Parkinson's-like symptoms, which are things like slowness, stiffness, occasional tremors, difficulties with walking. But there's different types of Parkinsonisms. So there's different things that make people look Parkinson's-like is what that means. And there's just a list of them. And then there's drugs, there's different types of Parkinson's, there's strokes that cause it, normal pressure hydrocephalus. Some people just with dystonia or tremors can look like Parkinson's, but also just other things, age, arthritis, deconditioning, neuropathy. Things will just add up over time to make people have a little bit of Parkinson's. Basically, everybody at some point later in their life will develop Parkinson's-like symptoms. But the question for the doctor ends up being, well, is this Parkinson's disease, which is very different than just Parkinson's symptoms. But how do we make that diagnosis? Well, generally, we think of it as a clinical diagnosis, which means that we hear your symptoms, we hear the time frame, and we do an exam and see what things look like. And to make the diagnosis, you have to have a couple criteria. The first is the slowness of the movements, which is why it's bolded there. You have to have that technically to have Parkinson's disease, though theoretically the tremor predominant ones, you can have a little leeway with that. So a little bit of slowness, usually there's some stiffness that coincides there. Sometimes there's a resting tremor. Early on, it might only be 1 in 3 people or so. It becomes a little bit more predominant over time. And then it kind of depends what the other motor and non-motor symptoms are. And you can support this diagnosis based on progression, because Parkinson's is progressive, so you would expect over time things to change. A response to the medications is very helpful to decide whether or not it's a Parkinson's disease. And there's a couple miscellaneous scans. There's a DAT scan and a skin biopsy. A DAT scan is a specialized scan called a DAT, stands for dopamine transporter. And so it's looking to see if there's low dopamine in the brain, essentially. It's really only approved to distinguish Parkinson's from essential tremor, but people will use it kind of off-label and kind of just fudge the data just to make sure to see if people, if they can get some more support for some questionable diagnoses. By no means is this necessary for the diagnosis, nor does a positive DAT scan even imply that giving a medication is even useful, to be frank with you. So there's limited utility, but lots of people use them, and it really depends quite significantly on the context of it. So you may get a DAT scan in your life. You certainly don't need one. It depends on your certain situation. The skin one biopsy is pretty new, a couple of years or so. It looks for this abnormal protein that builds up in Parkinson's disease. We think that Parkinson's disease changes a protein, and then those proteins go and bump other proteins and changes them too. And this really slow propagating process over the span of decades and decades. This protein, we don't know if it's really causing the problem versus just a byproduct of whatever the heck is happening. So quite frankly, we're still in those early stages of figuring that out or not. But that protein gets places, and we think when it's there, either the damage has been done or it's causing damage. And we can see that it gets in the skin these days with Parkinson's folks. Not everybody, and everyone's different, and some different genetic causes don't have it. But if you do a skin biopsy looking at the neck, the back of the neck, the thigh, and the ankle, you look for that protein. So you're looking for synuclein, which is the abnormal protein. If we see that, it supports the diagnosis. It does not prove it. Some people just have it just with age because it's a byproduct of wear and tear on the body as well. So it's used to be supportive, and it really depends on the clinical context on when you're going to use that test versus even interpret it to be positive anyway. But then what do we do as far as treatments go for the motor symptoms? And so we use basically dopamine stimulating medications. So really what that's the way of saying is we give you battery. We're giving you dopamine, levodopa, to help people feel like they have better control of their body. And so it's very helpful for things like slowness and stiffness. Tremors vary. It can be hit or miss. Sometimes it's super high dosages. Sometimes it doesn't matter what I give you. You're going to tremor unless I burn a hole in your brain or put a battery in your brain. And so really the slowness and stiffness is what usually is remarkably improved. But lots of things can change, and that can be mood, walking, cramping, swallowing, etc. So everybody's kind of choose your adventure, find out what gets better. But we focus primarily on the physical limitations because that's what the medicine helps for, which is slowness and stiffness. So you'll see all sorts of different versions of it. Carbidopa, levodopa is the tried and true. That's been around a very long time, I think since Henry Ford or something like that. But the carbidopa protects the levodopa. That's why it has two names. The levodopa is the L-dopa. That's what we actually need. And the carbidopa prevents it from breaking down in your bloodstream so that it can get through the blood-brain barrier and feed your brain and give you the chemical it needs. So that's the generic name. The trade names for that, Sinemet, Rytary, Crexont, Vialev is a new infusional pump. Just know you can't use it at a lot of nursing facilities. I don't have any experience with it quite yet. And then there's other ones too. There's dopamine agonists, things like the ropinirole, pramipexole, etc. MeO-B inhibitors like rasagiline or selegiline, COMT inhibitors like opicapone and Stalevo and Comtan, amantadine, etc. The thing that's important to know is that the medications don't actually change the course of the disease. They've done pretty good studies on this, long-term studies. If you take medicines early, it's not going to make your Parkinson's shorter or longer. It's not going to make you respond to the medicines more poorly or better in the future. All it clearly does is improves quality of life. If somebody cannot use their body because they are short on a chemical and we give them that chemical that they can use their body better, that improves quality of life. But it does not fix the underlying problem of Parkinson's, which we can't fix yet, which is that something is breaking down in the brain in a way that causes these Parkinson's symptoms. So don't be fearful of the medicines per se, because they do help. And we've proven with really good and fancy studies at this point that the medicines are dramatically helpful for quality of life, if not more so early on in the disease. So you may as well use them. You'll notice from this point going forward as well, I have some links on the bottom right. And these are just to our Inova Parkinson's and Movement Disorders Center. So these will be here. So obviously you can copy paste the link later or type it in, but this is just would take you to a page that talks just a little bit about medications specifically. There are some surgical approaches that's beyond the scope of this topic, and we're not going to talk much about it, but people will do deep brain stimulation where they put electrodes in your brain. Some people will do focused ultrasound where they burn a hole in your brain, and that's not what we're going to talk about today. It is kind of worthwhile to talk about what we think about as far as physicians go, how to make adjustments with medications. It's helpful when caregivers and patients have a sense for what the heck we're trying to do, because that gives us more knowledge too. And we're by and large consultants. We get information, we tell you what we think you should do, but the more information you have, the better we can tell you. And so every time someone takes levodopa, you're basically just getting a boost of dopamine. And usually it's a pretty short lasting boost, especially with Cinemet. So it's, that's oftentimes why people take it 3 times a day at least. We think about when the medications are working, that's called on time. So you're on your medicine, it's working, it's doing its job. When the medicines are not working, it's off time. It's pretty straightforward there. There's a couple things we use that to determine here. So the peak dose is referring to how well the symptoms are controlled when your medicines are at their best. So the medicines usually kick in half an hour, maybe maximum benefit an hour to 2. It varies dramatically. But the question for peak dose is, when that medicine has fully kicked in, how well do you feel like it's controlling your symptoms? Does it seem like there's some residual slowness, stiffness, tremor, etc.? And then the motor fluctuations are more so, are you experiencing off time? Do you take your medicines, go on, and then you go off before your next dose? So it's looking to see how many times or how often you're on throughout the day versus are you having these troublesome off times where you feel like the medicines aren't working. And depending on if it's an inadequate peak dose or there's frequent motor fluctuations, determines what we do. Bumping up the dose generally helps for inadequate peak dose, and taking medications more frequently or adding long-acting formulations, et cetera, those things can help with those kind of motor fluctuations. But some people will think about DBS and focused ultrasound as well. Incredibly unique decision. Dyskinesias are a very complex problem, quite frankly. There are these extra movements that people can't control, and they're because of Parkinson's disease, but they're brought out by your medicines, like dopamine-stimulating medicines like levodopa, Rytary, Crexont, etc. It's usually brought on when the medicines are their strongest. Every once in a while, maybe 5% of the time, it'll happen as the medicines are kicking in or wearing off. That's pretty rare, though. But they're really just, a simple put, is that the dopamine receptors, those things that are accepting the dopamine that we give it, they change too over time. They become hypersensitive, they break down a little bit. And so when we give people dopamine, those receptors that are accepting it, they just don't always act 100% right. And because of that, your body says, hey, I got some extra dopamine, I got to do something with it. It'll just make people move. And it's this irregular, kind of non-rhythmic, weird, non-stereotype movement. People just kind of fidget for the most part. It can look like tremor. It can be really hard to tell if it's a tremor or not. So if you see it and you're bothered by it, film it. Bring it to your doctor if they don't see it. That's helpful. They're not dangerous, and they're really not usually a problem. Some people have really dramatic ones, and if they're dramatic and they're making them fall, that's a big deal. If they're making people lose weight because they're just moving all day, every day, yeah, that's a bigger deal as well. But by and large, most people don't have dramatically bothersome dyskinesias. Maybe down the road they do. And sometimes you just have to accept it. You say, okay, the dyskinesia makes someone feel better, and that's okay. So people like Michael J. Fox, young onset, they're very oftentimes get dyskinesias. He is living with dyskinesias. He doesn't tremor. He fidgets around like this constantly because he is in his on state, because he feels better with dyskinesias. He has better control of his body, even if it's still doing its own dyskinetic thing. And then again, people might think about DBS and focused ultrasound. Sure. So what can be helpful though is sort of paying attention to, how is the peak dose? Are there fluctuations? Those types of things. So a diary can actually sometimes be helpful. Um, and this is just an example of a diary that we've created. This will be on the website, but as you can tell, it's very straightforward. Are you on? Are you off? Are you having a dyskinesia? Are you asleep? What comments do you have? Oh, yep, I had freezing a gait at this point. Ooh, I felt kind of anxious. It's nice to get a sense, because this will give us a sense for what are you like throughout the day, and is it regular, or is this maybe you just had a bad day? Because Parkinson's is going to fluctuate from day to day. Most people are pretty similar from day to day, though. But if you get a kind of routine where you're checking it out, you'll get a better sense for when medicines are working and when they're not working. So there are other things, though, besides medicines that are useful. So behavioral approaches, we call this. And really, I mentioned earlier, the medicines don't slow or speed up the disease. They improve quality of life. They give you more ability to control your body. But what that allows you to do is exercise more. And what we have seen, and there's pretty solid evidence, I'm not going to say it's amazing, but it's pretty solid, that people who exercise do better with Parkinson's. And maybe even theoretically, it slows down the progression of Parkinson's disease. And so exercise is probably the most important thing. That doesn't mean you go and try to run a marathon. There's actually good evidence that people who then go crazy with it and exercise like crazy, they make themselves worse. There are studies for that. It's just regular exercise. Exercise promotes dopamine creation in your brain. So it probably is telling your brain, hey, keep building these dopamine centers as best you can, because I need to exercise, and this is a movement chemical. But exercise is unique. So look at the resources below. There's a lot of stuff. There's online courses, there's in-person classes, physical therapists are helpful, but generally daily stretching, because people get tight with Parkinson's. There's Parkinson-specific PT, OT, and speech therapy. And yeah, sometimes with Parkinson's, people can be a little apathetic, so they don't necessarily want to work out. So it is helpful for caregivers to be encouraging and trying to get people to be more active. Because if you decondition, it's just that much harder to get back into shape if you have Parkinson's, because it takes more energy, it takes more effort, people are more fatigued. So staying on top of your exercise is exceedingly helpful. It doesn't mean you can't take breaks. It's absolutely not what that means. You can burn yourself out if you're aggressive about it. But you should not take too long of a break where, you're getting deconditioned. That's not helpful for you. So definitely look through the IPMDC's website as well, because there's in-person classes, there's online courses. You don't have to be in Virginia or local to do an online course. You can do whatever you want. So we'll talk briefly about gait and balance, because oftentimes Parkinson's does affect walking, and that can be a kind of early symptom. People might not swing the arm. They might kind of stoop over. They might shuffle their gait a little bit, might not swing that arm. Shuffling is a bigger deal, because if you're scuffing your feet, you might trip on something. And if you trip, you're going forward. That could be a fall. The medicines are not that helpful always. It's mostly like you have to be thinking about your walking type of thing. You got to be telling your body, I want to be walking with swinging my arms and lifting my legs up strong. Medicines usually help a little bit. But I don't tell people, hey, expect to walk normally because I give you this medicine. Regular training, exercise, balance training, all that stuff is exceedingly helpful. Physical therapy is helpful. They teach you how to walk better. They teach you how to use your strength better and how to use your muscles. If you need to, use an assisted device, canes, walking sticks, walkers if you have to, because they'll keep you going longer if you need to, and they'll keep you from falling, because falling is always going to be a dangerous issue. And once it happens, it tends to keep happening. And so we want to prevent falls as best as possible. And that can also be having a home safety assessment to make sure you don't have tripping hazards like throwaway rugs or whatever. Making sure the house is well lit, not a lot of clutter. That tends to help too. But sometimes adding things like grab bars and seated showers, all those things. It's all sorts of things that can be helpful. And so you can always have like an occupational therapist come to the home and do an assessment, or you can just kind of look at it yourself and say, this does seem a little difficult. Freezing happens occasionally. A lot of people with Parkinson's will feel like their feet are stuck in place suddenly, almost as if like you're glued to the ground. The foot kind of stutters, almost tremors. That can be a big fall risk, obviously. It oftentimes happens when people have been sitting a while and they just stand up, or if they're trying to go through a small little doorway, turn around in a tight corner, that type of stuff. Those things where people are really kind of thinking about their walking more so, it tends to make it harder for some reason. Medications can be helpful, especially if it's clearly an off phenomenon, like the medicines are not working, now I'm freezing, but it's only so helpful. The behavioral techniques tend to be the most important thing. And so there are things you think about, the ABCDE plan. It's not really worth talking about this because you have the screenshot of it. And I don't talk about it any better than I talk about it worse than anybody else, honestly. Quite frankly, if you're freezing, you need to be working with physical therapy. They're going to be doing this one-on-one with you. So take a screenshot of this, read through it later, but let's not waste 5 minutes of me just reading a slide. If you do freeze, though, you should stay calm. You should take some deep breath. Weight shifting from side to side can be helpful. Sometimes they say taking a step backwards, if that is safe. Verbal and visual cues can be helpful. Make sure you try to get that heel firmly on the ground and do heel toe when you're stepping. And caregivers don't pull and tug, but you can gently try to guide. That does sometimes help as well. Speech and swallow can be commonly impacted with Parkinson's. People are oftentimes quieter with Parkinson's. Almost everybody I see with Parkinson's has a quiet voice. And that can be an insidious finding. That could be something that had been going on slowly over the spectrum of a couple of years before people realized it. I don't really expect the medicines to be particularly helpful. Really, they don't seem to be in my experience. What I often see is that behavioral things, like doing LSVT loud, trying to speak with intent, speak loudly, those types of things are helpful. Occasionally, people have a little bit of trouble swallowing. And that can be early on, and sometimes the medication helps for that, but that varies quite a bit. It's important to work with a swallow therapist if you have any trouble swallowing. And the swallowing specifically to liquids, I should say, because the swallowing pills and breads and big meats and stuff like that, that happens to everybody. It's a fleshy tube that we take advantage of our entire life. It's the liquids that are more bothersome and can happen with Parkinson's, because that's a coordinated effort that can break down sometimes with Parkinson's disease. And so it can be helpful for for caregivers to help with meal prep, reminding to chew food, and using swallowing techniques that a speech therapist would tell you to do. It's really speech therapy is key there. Occasionally, people drool, call that sialuria. That's not actually due to more saliva production. I actually recently read a paper that said, if anything, Parkinson's folks maybe produce less saliva. It's more so that you're not swallowing as often. And so we swallow automatically like 1 to 4 times a minute or so. They think Parkinson's folks maybe swallow half a time a minute on average. And so if you're not swallowing unconsciously that saliva that you're building up constantly, because we have a steady state of saliva we're constantly producing, yeah, you're going to build up saliva and you'll have to swallow it. There are medicines, but quite frankly, there's a big risk of confusion with them. And I've seen that quite frequently with the medicines that I've tried before. Botox injections, botulinum toxins, also Xeomin, Myablock, all different types of it. Those can be effective. Sometimes it might cause cavities if you have excessive dryness, though. So it's always important to get a regular checkup. Plus, you have to do Botox every 3 to 6 months. It's a poke, usually 2 to 3 pokes or so. It can be a little bit painful, but most people tolerate it pretty well. But there's other behavioral stuff that works. So reminding yourself to swallow, which is easier said than done. Sometimes sucking on a hard candy can be useful. Or you just say, hey, I'll jewel every once in a while, I'll have a handkerchief. So there's some behavioral stuff you can do as well. Appetite and weight loss can commonly be seen with Parkinson's as well. There's numerous reasons why someone with Parkinson's disease can have weight loss and loss of appetite. Loss of sense of smell, mood changes, troubles with eating food, slowed gastric emptying, which fills you up more, constipation, which makes you feel more full than you are, definitely medicines, and certainly just the fact that with Parkinson's, you move more and it takes it takes more energy to move. And if you have dyskinesias, you're moving at rest. And so you burn calories doing that. And if you have poor caloric intake, plus you're using more energy and you're losing weight, you can lose the muscle atrophy. You can weaken and decondition. So it's important to try to stay on top of that. Medicines are only so helpful for stimulating appetite. They can help, but they're not amazing. Sometimes medication adjustments, depending on if it's a motor issue, that can be helpful. But behavioral stuff is helpful too. Monitoring weight, adding high-calorie, nutritious snacks. Try to avoid protein. Theoretically, interferes with your ability to absorb the medicines. That only affects some percent of people. So maybe if you're going to do a calorie, like a protein shake, maybe just do it in between your dosages, like 2 hours after. Small frequent meals can be helpful if you're getting full easily. And working with the swallow team, if you feel like, oh, it's just hard for me to swallow these things, yes, work with that team. They will help you try to maximize that there. Constipation is extremely common, and it's something that can manifest decades before people actually get Parkinson's. It is important to try to have a bowel movement pretty regularly. If you don't go at least every other day, you're at higher risk for an impaction, which is a way of saying the stool can't come out, basically, because it's so dry and it's balled up, basically. So it's important to try to go at least every other day, because a fecal impaction will be a terrible day for you, because you have to go to the emergency department and somebody has to disimpact you, which is a very unpleasant experience. There are lots of good ways to treat constipation, though. I haven't seen very many fecal impactions in my experience here. Behavioral stuff, diet changes, over the counters, and sometimes even a fancy prescription medicine that sometimes you have to go see the gastroenterologist for. Here's my simple algorithm, and I'll read it briefly, but this is all online, and there's numerous formulas you can find. Water, 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 definitely. More activity stimulates your bowels. natural fibers. If needed to, add a bulking laxative like Metamucil. It's also called psyllium husk. If you need to, then you can add Miralax. If you need to, you can add a stimulating laxative like Dulcolax. If none of that stuff works, keep exploring different things that may work for your body, but you can always see a gastroenterologist to think about some of the fancy medications that tend to kind of break the bank, to be honest with you. Plenty of Parkinson's folks have urinary symptoms. Plenty of everybody I know over the age of 50 has these identical urinary symptoms, but there's definitely a correlation here. My folks with Parkinson's tend to have frequent urination, urgent urination, and going overnight as well. The problem is this causes people to drink less water, which is not good because people with Parkinson's need more water, if anything. And a lot of the bladder medicines are not really ideal for Parkinson's folks. They can cause low blood pressure and memory issues. The thing now, it's overblown probably. I've seen plenty of patients do well with the quote unquote unsafe ones, but the safe ones I prefer. And those are things like Myrbetriq, which is also called Mirabegron, Gemtesa, which is Vibegron, and Sanctura, which is Trospium. There's other strategies. Timed voiding is helpful. We'll talk about that in a second. Reducing water intake overnight can be helpful for the overnight urination. Just using a bedside commode or committing to adult diapers, that might be necessary too. Some folks benefit from physical therapy to help with bladder training. I don't entirely understand why that would work, but they do. Something about tight muscles in the pelvic floor seem to stimulate overactive bladder. Timed voiding is something where you just kind of track your bladder use. You write how often you go. You're saying how dark the stream was. You're saying how urgently you had to go. And then you're trying to go before you would have to go urgently and then slowly train yourself to go later on, to kind of push it. So it's a strategy people can use. And there's apps for it and all sorts of things. Orthostatic hypotension is a way of saying that blood pressure drops by at least 20 points when you stand up compared to laying down or sitting down. It's pretty common with age, but more so for folks with Parkinson's. It's very common at some point. 60% of people with Parkinson's will have this problem. It can manifest in many ways: lightheadedness, dizziness, weakness, fatigue, sleepiness, brain fog. If severe, someone could actually pass out. It can happen right when you stand. It can happen within 1 to 3 minutes, or it can happen after 3 minutes. There's all different ways of classifying it. There's many things that make it worse. One is Parkinson's disease does do it. Medications definitely do it as well, especially the anti-hypertensives, your actual blood pressure medicines, bladder medicines as well. But even our Parkinson's meds do it too, unfortunately. But dehydration is the biggest risk factor, especially if somebody is bothered by urinating frequently and going overnight and they stop drinking water. Dehydration always makes the symptom worse. And so, I just said that. But there's a couple simple blood pressure medication or measurements you can do at home that will tell me if it's actually a problem for you. And the treatment, regardless, is almost always you got to drink way more water. The next step is usually removing blood pressure medicines. And then theoretically, we might even have to add medicines to kind of boost that blood pressure just so it doesn't drop. Because if it is and you're passing out, that's a bigger deal. So there are some ways to check your blood pressure at home. You get a blood pressure cuff. I don't have recommendations. You lay down, usually do it first thing in the morning, wait 5 minutes, let your blood pressure calibrate where it wants to be when you're laying. Take your blood pressure and your heart rate, sit up, wait 60 seconds, take it again, stand up, wait 60 seconds, take it again. Some people will make you wait 3 minutes. That's kind of a lot of time. I'm usually pretty content if we just do 60 seconds between there. And so you just take it first thing in the morning for a week. If you want to and you're on blood pressure medicines, you can wait an hour after you take your blood pressure medicines and then do the whole thing again. And then we can find out if the blood pressure medicines are clearly causing the blood pressure to drop. There's some other times to take it too, though, especially if you notice brain fog when when the medicines have kicked in. That's probably low blood pressure, because my medicine, when it's maximally kicked in, will oftentimes drop blood pressure a little bit. So take it maybe 1 to 2 hours after the medicines to see if that's making any difference. Take it if you feel anxious or out of body. Brain fog or spacey, definitely. If you're lightheaded when you're standing, if you're sleepy after a meal, because meals will drop blood pressure sometimes, or if you fall. It might be that you fell because your blood pressure was really low. There's a lot of non-medication treatments, and this is very much a busy slide, so read through it later for the most part. But water is the takeaway there. Salt can be helpful. Water follows salt, so if you have more salt in your body, water will stay in your body. But take your time when you stand up. You can try some pre and post standing exercises. You can YouTube those. It's on our IPMDC link at the bottom. Big meals, especially bready meals, can drop your blood pressure. Alcohol drops blood pressure. You could think about compression stockings if this is an issue. You could even think about abdominal binders. That sometimes shifts blood away from the abdomen back into circulation, just so you can have a better cardiovascular system there. There's some techniques you can try if you do feel lightheaded. If you think you're going to pass out, just sit down. It's not a good idea to do a deep squat or to do calf raises or to tighten your glutes if you're about to pass out. Because if you're going to pass out, you're going to pass out. Just sit down and be safe. Caregivers can be helpful by making sure you're very well hydrated and looking for signs of dehydration if that's possible. But sometimes if you're going on a walk and you know this is a problem, having a walker with a seat attachment or going in a place where there's seats, like a park that has a lot of benches. If you're lightheaded, drink 12 to 16 ounces of water over 5 minutes. It's just as fast as and effective as getting an IV infusion. So if you feel lightheaded, drink 12 ounces of water. You'll probably feel better over the next 20 to 30 minutes or so. But if you're going to faint, if you feel like you're going to faint, you have a hint of it, just sit down. Go down. I'd rather you be sit down and then pass out and hit your head when you're low to the ground versus I'm standing and walking and I bonk my head. That's a much bigger deal. The opposite problem can happen too, as far as low blood pressures. Some people have supine hypertension. So when they're laying flat, their blood pressure is high. And that oftentimes coincides with orthostatic hypotension. And sometimes it's my blood pressure is really high when I lay down and it's really low when I stand up. And we oftentimes say, okay, we're going to tolerate the high blood pressure because that's not a big deal in the immediate time frame. Low blood pressure knocks people out, which can kill them. High blood pressure, yes, it's bad for your brain and your heart, but over the spectrum of 5, 10, 20, 30 years. So oftentimes we accept some high blood pressure, but that varies dramatically. We get those measurements when you do the laying down measurements. So that's what it'll tell us. And yeah, we probably don't want it over 180, but it varies from person to person, especially if they're passing out regularly. The non-medication stuff is still similar, but if your blood pressure is high when you're laying down, yes, you should then avoid laying totally flat. Usually 30 degrees is very helpful. And you could even take the blood pressure again, find out, okay, actually it's not quite as high when I'm laying at an angle. But avoid laying down flat throughout the day. So if you're going to take a nap, use a recliner. And sometimes even eating a small carb snack can be helpful. A carb dense snack right before bedtime that can drop blood pressure. If you're going to go to bed and have your blood pressure raised, it can just drop it ever so slightly, which can be helpful. Poor sleep, pretty common with Parkinson's disease as well. Common with everybody, quite frankly. It seems to be an age-related phenomenon for the most part. But yeah, lots of people with Parkinson's have trouble falling asleep, staying asleep, and or waking up early. It could be from a lot of reasons, from the medicines wearing off, anxiety, going to the bathroom, pain, poor sleep apnea, etc. The medicines are only so helpful. It varies dramatically. You should always try melatonin. And certainly our Parkinson's medicines, sometimes if we add a bedtime dose, can help. It varies, though. You have to find out the root cause for it. And certainly sleep hygiene and cognitive behavioral therapy for insomnia are useful. So those should be used, as well as melatonin, followed by whatever medication adjustment someone might need to make. So this is just brief sleep hygiene. Yes, trying to go to bed and wake up at the same time every day. Do not use your bed for anything but sleep and intimacy. Try not to do super stimulating stuff right around bedtime. That's just going to wake your brain up. Don't watch TV. Don't play on your phone. Blue light is not good for us as we're trying to go to sleep. Relaxation techniques, etc. Just read through this stuff on your own. Cognitive behavioral therapy as well. You can try to retrain your brain to sleep because some people do train themselves to accidentally not be able to sleep well. It's very common. But there's different levels you can do. It can be I'm going to read a website or download an app. I'm going to read a book. Level 2, you could try some courses. Level 3 is you can meet with a therapist, a special cognitive behavioral therapist. You do one visit a week for 5 to 8 weeks. You pay out of pocket usually, and you see if they can help you fall asleep a little bit better. REM behavioral disorder is occasionally present with folks with Parkinson's. So RBD is really vivid, lifelike dreams. People are chasing you, attacking you, sleep talking, complex dream enactments. I'm like reaching out, punching people, grabbing flowers, whatever kind of random things. But even sometimes I get up and fall out of bed. Melatonin can be helpful. Occasionally, people will use benzodiazepines to try to just sedate someone so they don't thrash themselves out of bed. But they do cause confusion and they can make people confused. So oftentimes that's sort of a if we have to situation. But certainly behavioral things are helpful too. And that's make sure the bed is low, use bed rails if you have to, make sure the bed's not next to something sharp, like a sharp corner or something like that. If you have sleep apnea, yeah, sleep apnea does trigger REM behavioral disorder as well. So treat that. Certainly thinking and memory are changed with Parkinson's. It's not something that oftentimes presents super early. It's something that we would expect down the road, but I'm not going to give that talk today. That's too much to expect. That's a whole talk in and of itself. And IPMDC already has excellent and free presentations given by Dr. Lawler and Dr. Palderai. Dr. Lawler is a movement disorder specialist. She's been doing this for decades. She's excellent. Dr. Palderai is our new cognitive behavioral expert, and she's extremely smart. Watch her talks. You'll get a lot of good resources from there. It deserves its own talk. It's not something we should race through today. But we're going to get into the kind of next section is just what do we see as far as progression of Parkinson's disease. And so, as I said, it's a progressive neurodegenerative disorder. So it will get worse with time. But the good news being it's relatively unique. So people's brains break down and change, but just because one person's brain changes in one way doesn't mean that if somebody has an identical brain change, they're going to act the exact same way. It's way more complex than that. So everybody is extremely unique. You'll hear it, and I've said it obviously before, but you see one person with Parkinson's, you've seen one person with Parkinson's. Everybody is their own kind of unique version and flavor of Parkinson's disease. And generally, people do really well. I mean, it tends to affect people at older age. So quite frankly, life expectancy is already kind of shortened regardless at that point. But most people have a very normal life expectancy. And a lot of people have extremely meaningful lives regardless. They live well with Parkinson's disease. And the problem is you can't say, okay, you have Parkinson's, you're going to have this problem in 5, 10, 20 years. I can't know how yours is going to progress. And even if I know you for 10 years, I'm not going to know how it's going to progress. It's extremely difficult to predict progression. Generally, age seems to be a good sense for how someone will progress. The younger folks tends to be slower, but they have their own problems. More dyskinesias, more motor fluctuations. They tend to have a lot of impulse issues, a lot of emotion dysregulation, those types of things. The older folks, yeah, it tends to be a little bit more rapid. Part of that is age, probably, but there's also more cognitive issues, imbalance, troubles with the bowels, troubles with blood pressure, those types of things. Generally, we think motor fluctuations can occur within 5 to 10 years of symptom onset. I've certainly seen people have them right away. I've seen people that don't have them for a very long time. That varies dramatically. Postural instability, so troubles with balance, cognitive impairment. Yeah, I mean, once that stuff happens, it's usually sort of a bad sign, but you don't generally expect that type of thing to happen for probably about 10 years. Again, ton of overlap, ton of variability with that. So I don't talk much about stages. I talk a little about the phases of it, but it's not worth talking about the Hoehn and Yahr stage 1 through 4 or 5, whichever it is. They're really not helpful anyway. The preclinical phase would be, yeah, things are changing, but so minimally that your good brain reserve is not impacted by it. Maybe there's some minor symptoms that nobody would ever be able to tell. The prodromal phase is the sort of, okay, maybe there's some of these non-motor symptoms, my loss of smell, REM behavioral disorder, constipation. Maybe there's some minor motor stuff. Maybe there's an action tremor in there. You never know. And then the clinical phase is, okay, I have Parkinson's disease. I meet the criteria. I have slowness in my movements with stiffness and or a tremor potentially. And this is sort of like a basic, this was made in 2015, but a basic kind of progression of Parkinson's. You can see the premotor kind of prodromal phase, oftentimes constipation, might get some dream enactment. This can vary from 20 to 50 years before. Loss of sense of smell, you can see 5 to 10 years before. That varies dramatically. And then, yes, once it comes, there's slowness, stiffness, tremors. People might have a little bit of pain, fatigue, some troubles with their memory. And then maybe 5, 10 years down the road, some fluctuations, some dyskinesias. But yes, cognition gets worse with time. People can have really significant changes with their memory and thinking. People can have trouble swallowing, troubles with their balance, falls, et cetera, et cetera. So obviously, Parkinson's disease is degenerating. It does get harder with time, but people do exceedingly well for a very long time and they live very meaningful lives, even beyond these 10 plus years here. This is a way we do think about the motor fluctuations and dyskinesias. It's a busy graph, and I can't make one better, but the y-axis is the blood levodopa, so how much the dopamine is in your blood system. The x-axis on the bottom is just how many years from symptom onset, basically. So the light blue is I'm feeling good, I am on. The dark blue is I'm feeling off. The red is I'm having a dyskinesia, and the gray lines are just your boosts of Cinemet. So we're just saying, like, you take a Cinemet 3 times daily, there's your boost. At some point down the road, you might notice, oof, it's wearing off. I'm getting some symptoms here. At some point down the road is, oof, I'm on, but I have dyskinesias, oof, and then I'm off, and now I have to redose it. Oop, I'm having dyskinesias, etc. And then down the road, it can be sporadic, it can be random. It can be I'm on, but I'm suddenly off, etc., etc. Because as those dopamine receptors break down with time, which they do, they just can't process that dopamine that we're giving it. Even if we're giving it dopamine, it's just not going to access it 100%. And so I've tried to subdivide this into kind of like early, middle, advanced stages. And this is a ton of overlap. Take this with a huge grain of salt here. I've decided to say early is 0 to 8. Okay. And I've made that up on my own experience, and I've only been doing this a handful of years. So cut me a little slack here. But generally, what I would expect is that, yeah, there's going to be motor symptoms. By definition, you'll have motor symptoms. They could be mild. They're going to respond really well to medications. There might be some fluctuations. There might be some dyskinesias. Typically, that shouldn't be a prominent problem, and they'll oftentimes be well controlled, whether or not by adding or adjusting medicines to be determined from person to person. And there might be some mild symptoms, non-motor things like, yeah, I'm a little forgetful. If you told me a 3-step command, I might kind of get lost or something in that, or maybe I'm not quite as confident in my driving, things like that. But by and large, people are independent with their daily activities. They're doing things on their own. They're doing okay. So caregivers, what you should do, support independence. That's important. Set up exercise routines, set things to be planned. That's helpful too. Regular schedules are exceedingly helpful for Parkinson's disease. Encourage activity, go in person, meet other people with Parkinson's disease, live your life. Absolutely, definitely. You better be doing that. But yeah, watch for things. Mood changes, those can be subtle. Now, my folks always say that their spouses or care, whatever, their loved ones with Parkinson's are depressed. And sometimes it's tricky because if somebody has a blunted facial response, yeah, you can look angry with Parkinson's and not be. So just ask the person with Parkinson's if they are sad too. Don't just try to say, oh, they look sad, because honestly, it's really hard to tell with Parkinson's sometimes, but they also might be. So do ask them, and I will ask them too. But watch for lightheadedness with standing. If someone stands and they're like, oh, just keep note of that. Watch for some sleep problems. Make sure people are having regular bowel movements, urinary symptoms. These are things that patients should be able to do. But never a bad idea to think about the future and to think about legal planning, financial planning, those types of things. Not that you're anywhere close to that, but while people are doing really well, while somebody has a really good brain reserve and they're thinking and their memory is the best it is, yeah, you should probably be thinking about the future just to make sure you're setting yourself up for success. The middle stages, which I'll say 5 to 15 years, which is a huge range, things become harder, obviously, because Parkinson's is a hard problem down the road. And so, yeah, motor symptoms are probably going to be a little more bothersome. They should still respond. They always respond to medicines, but you might feel a little bit more unsteady, the kind of 10 plus ish years or so. There are probably a little bit more fluctuations. You might be taking the medicines a little bit more regularly. You might have a little bit more bothersome dyskinesias. Typically 5 to 15 years down the road is when people think about doing things like deep brain stimulation, focused ultrasound, those types of things too. But it's important to watch for changes in thinking and memory, low blood pressure with standing, more bothersome urinary symptoms. And yeah, because of some physical disabilities, it might be helpful for a caregiver to give a little bit of assistance for things just to kind of make sure that everything is going as should be. But probably a good idea to assess home safety, help with walking if needed, certainly continuing to encourage activity. And yeah, you should go in person, but if you need to, you can do online courses. That's certainly helpful too, or online classes. But it's helpful to have that keen eye from a caregiver to pay attention to dyskinesias and motor fluctuations. Because even my early stage Parkinson's folks, they're not always reliable narrators. They don't always know. They're just living moment to moment in their body, and they can't always appreciate if a medicine's working or not working. And that's just the way that we're wired. It's like how we wake up if we're in a dream and we're doing something really weird, we don't really think it's that weird in the dream. We're just kind of living moment to moment. So a caregiver can be very helpful just to see, oh yeah, it looks like they're wearing off maybe an hour before their next dose. Or yeah, right when that dose kicks in, an hour in, they're doing really bad dyskinesias. And so that's where the Parkinson's diary is helpful for that as well. But things like choking on liquids, mood changes, et cetera, et cetera. It's good to have a keen eye to attention to those things too, just so that everything can be addressed. And at this point, definitely the idea to think about long-term care, feasible to be in our home where we've lived for this whole time, or is this something that's setting me up to have a really bad time down the road because there's a lot of stairs and rugs and all of those things. But even so, it's never a bad idea to work with a palliative doctor. And palliative doctors just take a step back and think, how do we want end of life to be? Do we want a feeding tube? Do we want to do chest compressions if your heart stops? Do we want to put a breathing tube down your throat? How would we come to these decisions when they probably will arise at some point? Because first off, they're going to happen to everybody. But with Parkinson's, there's a whole host of other things you have to think about. So it's never a bad idea to get palliative care involved. It does not have to be super early, but it's good to make sure that you have a set plan and that when that plan comes, you're ready for it, or at least you kind of know, okay, if this happens, I was going to do this. If this happens, I was going to choose between these two things. The last thing you want to do is be surprised, because almost always you'll kind of err on the side of excessive doing. And in these situations, excessive doing is not always the best for people. So you just have to think about these things. Advanced stages, which can be anywhere from 10 to 25 plus years, and incredible variability there. But obviously advanced is when medicines don't work that well. They still work. People are worse off the medicines, but yes, those receptors are only going to accept the medicine so well. And falling is going to become more of an issue. It might be to the point where I'm stuck in a wheelchair and maybe I'm just getting up with PT, or maybe nope, I'm just doing stretches on the bed before bedtime type of stuff. Cognition can become more of an issue. People with Parkinson's down the road, because kind of just generally anybody down the road is high risk for dementia at some point. But yes, Parkinson's folks, 80% of the time, with enough time, will develop some sort of dementia at some point. And that can be hallucinations and kind of weird thinking as well. So paying attention to that is helpful. Troubles swallowing down the road can be very difficult, and that's a decision for whether or not somebody will do a feeding tube. And even the low blood pressure, that tends to be an extremely bothersome symptom for people, because if it's low when you stand, You decondition because you don't get to stand up quite as much. And then even bladder issues. It's all the slowness. I don't have time to get to the bathroom. My bladder is not giving me a second before I gotta go. So it's challenging, obviously. And a lot of people need help with most of their daily activities. So caregivers are doing a lot here at this point, and it's deciding, it's helping people stand and walk, watching closely, maybe hands-on assistance, potentially having some home health aid, or even saying, hey, this is a lot. I can't manage this on my own. I need someone to get nursing care. And that's reasonable. That's something that does happen to folks. But oftentimes they're kind of owning the medicines unless they're at a facility. I know that they're taking it at this time. I'm giving them this much every time. It does this much. And they're watching. They're saying, I see this change in them. I see that change in them. I've noticed that this or that happens. And they're my reporter. They're the person that's telling me what's happening so that I can help. And when things eventually happen where end of life things are happening, it's important to follow that plan. And that's why you don't want to wait until someone's demented to have these talks. You want to talk to somebody while they have good brain reserve and while they can think and say, if this happened to me, I would not want to put you through this or that. I would not want to put my family through that. I would not want to put myself through that. And that can be as aggressive as you want to be, as conservative as you want to be. That depends on how you were born, how you were raised, how you feel about the afterlife, all of that stuff. Incredibly unique. I will never tell you what to do with your life. I may suggest things, but this is a decision you get to make. And so the important takeaway with this for the most part is that people can live well at every stage of Parkinson's disease. And it's important to focus on the meaningful connections and those daily moments of joy. People learn a lot about each other through Parkinson's disease, through just living through it. You learn about your caregiver, the caregiver learns about you. It's a challenging disease, but it brings people together. It brings family and communities together. And it's exceedingly important to use the resources we have. Your care team, which is the doctor, the PT, OT, speech, the nursing staff, the social worker, et cetera, the community resources, and family, obviously, which is probably the most important thing here. We have incredible resources, and I've showed you links to them before. I'm going to give you a link at the end, too. There's the IPMDC. Obviously, the program that we're with right now is incredibly lucky too. I mean, we're lucky to have these resources in a lot of places. And I even read the blogs sometimes. It's depressing when I see these people who are asking these questions where it's like, I cannot believe you're asking such a simple question. Where is your team that's helping you? So please take advantage of our resources, because the more knowledge you have, the better you will do, both caregivers and the patients, and the better success you'll have down the road. And the other caveat with this is caregivers, down the road, it's hard for you. You're probably, unfortunately, unappreciated aspect of Parkinson's care, which is really frustrating, I'm sure. But you got to take care of yourself too, because if you don't feel well, certainly the person you're giving care to is not going to feel as well either. So you have to try to take time for yourself as well, which is obviously way easier said than done. But a part of that is you're not alone. We do have help, and we have a lot of good resources, even if, unfortunately, the American healthcare system is not that great. We here at IPMDC, we do have a lot of ways to have us navigate this less than ideal American healthcare system too. So reach out as best as possible. And Sonia is amazing. So Sonia Gao is doing an amazing job. So please, if you want to reach out to her, she's always happy to go through emails and all sorts of information, talk with people about all sorts of things that are helpful. And I have a social worker that I work with for my specific patients too. But the journey is challenging, but you can find hope and you can find purpose every day. So it's important to live with hope with Parkinson's disease and to find the things that bring you joy and to bring you connection with family and people around you. And so with that, I do want to give a special thanks, obviously, to the Inova Parkinson's and Movement Disorder Center. Sonia Gao has really created an amazing website with resources that I've been working with her for the last 2 years to update and just to get to be a hub. I think it's a really good website. I send it to everybody, and you can send it to your friends in different states. They are well able to use this website. It's online resources. You don't have to be in Virginia to use it. I think it's better than the Michael J. Fox website. It's better than a lot of the websites I've seen. So we put a ton of effort into it, and it's free. It's free. Feel free to donate. It doesn't go to me, that's for sure. But definitely, it's a free resource that's extremely useful. The Fairfax County Department of Family Services, obviously, thank you for putting this together. And they've done other things with Dr. Paul Durai, and she's done some excellent speech talks as well. So thank you for putting this together. It's been extremely helpful. And obviously Sonia again, because Sonia is an incredible resource in the Parkinson's community here and across the United States. And even if you're across the world, sure, you can use us, is lucky to have her. And then obviously, thank you all for being here, because you guys have been, you guys are the most important ones. You are the stars of the show for the most part. So I hope that this has been helpful for you guys. I actually finished up 5 minutes early, and I cut about 45 minutes off from my last attempt at this. But this will be all available in the the link that they'll give you that has the recording plus just the slides that you have it. I'm not like copywriting this or anything like this. This is all my opinion for the most part. Feel free to share it with friends. If you try to sell it, that's mean. Don't do that. Give me some money if you do that. But I'm not trying to sell this stuff or anything like that. This is freely accessible that I'm using, as I've stolen from all the educators I've had before me that have learned about Parkinson's for decades and decades. This is me giving you my summary of how they see Parkinson's as best as possible. So with that, I'll stop sharing my screen if I can figure out how to do that again. And then we should have time, at least 5 minutes or so, probably a little bit longer, for some questions.
Yes, thank you so much for your thorough presentation. Now I would like to invite the audience to submit your questions in the Q&A box.
Hopefully I didn't put too many people to sleep today.
So there is a question, how to plan for the progression of the disease? What will it look like in 5, 10, 15 years?
Well, I do feel like that was a part of, I would probably just review part of the thing. I can't tell each individual person how to expect it. It's an incredibly unique, we call it heterogeneous. One person is not the same as the next person. But generally, yeah, I would go through those kind of like early, middle stage, late stage things. Take that as a generic, more of like a generic rubric, because everybody is extremely variable with that type of stuff. But early on, yeah, I mean, you should be working with your neurologist to manage the motor symptoms. You should probably think about financial planning. Middle of the road, yeah, you always work with the neurologist, keep making adjustments. You think about DBS if you're a candidate for it. And then you think about sort of palliative care type of things. What would I want to do in 5, 10 years if I had a heart attack or a stroke or whatever? And then, yes, end of stage, it's challenging. It's things working with social workers, working with palliative team, working with your neurologist. And so for like individual questions, or if it's like, what about me specifically? You got to talk to your doctor. There's no way I could ever tell you.
Okay, thank you. How can fatigue as a side effect from drugs, how can that be managed?
That's a very difficult question. And one, it'll be, is it truly from the drugs or not? If it is, I would be nervous a little bit about, as I mentioned, to do the blood pressure. The blood, because it will drop blood pressure. So if you're taking it and 1 to 2 hours later, you're getting fatigued, yeah, your blood pressure is probably low. Take your blood pressure on the dose, or once you're 1 to 2 hours kicked in, take it seated and standing, make sure it's not tanking. If it is, well, then fix the blood pressure. That's the issue. And that could be more water. It could be removing blood pressure medicines. Maybe we need to give you less medicines. If it's just Parkinson's fatigue, which is common, and quite frankly, someone will, if it's just Parkinson's fatigue, honestly, the medicines only work so well. Our medicines work okay. It varies. Sometimes people will give stimulants. The evidence for them is pretty weak, to be honest with you. So I'm not expecting a stimulant to make you feel a whole lot better. And so most of the time it's living with fatigue and learning, kind of finding your envelope of how much energy can I expend in a day. But it's hard. It's a very unique question. So I couldn't do full justice to it.
Can vertigo be related to Parkinson's? If so, what might be the cause?
Vertigo would only be related if it's an orthostatic phenomenon. So if the blood pressure is dropping when you're standing up, which can be dizziness, room spinning. I had it yesterday. If I turn my head, I might have a vertigo attack. So if I do, I'm sorry, but low blood pressure will make people have vertigo, definitely. So it depends. If I'm standing up and then I just get vertigo, it's probably blood pressure. Check the blood pressure. Everybody that sends me any question, you should check your blood pressure. You'd be surprised. I've found some dramatic drops in blood pressure from people just say, hey, why don't you check it just because? And then we know it. And then they drink more water and a lot of symptoms get better. And so I would double check that. But also people will get vertigo for any other reason. And it does not have to be Parkinson's related by any means. So if it's not blood pressure, it's not Parkinson's probably. It's probably something else.
What dose of melatonin can be used at night? What can it increase? Can it increase the chances of falling when I get up in the middle of the night?
I usually tell people to do 5 milligrams, and I'll have them do it about 3-ish hours before bedtime. So you can do it 1 to 3 hours before. And one sleep doctor told me 3 hours is a sweet spot, apparently. And I usually say 5 milligrams, give it a month. You can go to 10, you can go to 15, you can go to 20 over time if you have to. I haven't seen people say it makes them particularly groggy in a way where They get up and then they fall. Some people tell me they feel a little bit groggier in the morning, but it's really not a sedating medicine. So I would, it probably does for some people, but that's probably more of a nocebo effect. I tell them I'm giving them a sedative. It makes them feel extra sleepy in the morning. Um, but I wouldn't think that it would cause people to fall overnight. That'd be unusual. The other medicines, the benzodiazepines, definitely, those are fall risks. But the other thing is when people get up overnight, they're more dehydrated anyway. They're going from laying to standing really quickly, trying to go to the bathroom, sit back down, pushing, standing, going again. That's big fluctuations in blood pressure oftentimes. And so people have to be kind of aware, take their time when they're getting up overnight because it's a huge risk factor for passing out, getting up overnight, using the bathroom, getting back up, going to bed. So extra hydration, but also staying high, being careful and taking your time when you're getting up.
And just to let the audience know, it is 1 o'clock. Dr. Reedy has agreed to stay on a little bit extra to answer some questions. So we will continue. So everyone will experience some type of Parkinson's in their lifetime.
I mean, it's not fair to say everybody, and that's more so saying Parkinsonism, which is so some slowness, some stiffness, maybe a tremor, but it would be an action tremor. So, I mean, not really, but kind of. It's one of those things where, yes, when I have people tap their fingers, my folks with bad arthritis, they can't tap their fingers very well. And my folks with essential tremor, yeah, they can't open their hands as well. So there's Parkinson's like symptoms. And yeah, if I have bad knees, I might walk by not lifting my feet up quite as high. And so in the end, age makes people look Parkinson's like sometimes, but that varies dramatically, which is why you see a neurologist who's an expert to try to figure it out. But I've been tricked. It's hard. I mean, this is not as easy as sometimes people make it seem. And so when in doubt, go see a neurologist. If they're confused, go see a movement specialist like myself, and I'll tell you why or why not I think you do or do not have a disease.
My mother is 89, incontinent, wheelchair bound, has lots of hallucinogens. She is taking carbidopa and levodopa. Do you think the next progression could be losing her ability to swallow?
Theoretically, that's possible. It's hard to know entirely if somebody will lose their swallow. If somebody generally lives long enough with Parkinson's, like theoretically, they probably would, and to some extent. But I can't say that with 100% certainty. It doesn't mean that for sure she's going to lose her swallow. I mean, what makes me more nervous is actually the thing disappeared. I can't remember. But if in the continence obviously is challenging, and if she's not getting up and walking as much, then yes, there's deconditioning, which is not great for the heart and just cardiovascular system. And if there's hallucinations, yes, that's challenging, obviously. So if anything, the take my more nervousness with that is the kind of like dementia aspect of that with the hallucinations. That's probably the thing that's a little bit more concerning for me. But it is a good time to think about, okay, well, if she did lose her swallow function, or if something did like some serious did happen to her, she's in the hospital for an infection or something, how aggressive do we want to be? Because she's living with Parkinson's dementia, and her quality of life has already declined. And so it's important to think about those things because you have to decide, well, would she want to live no matter what, even if she was kind of miserable with quality of life? And some people, the answer is yes. My grandfather had Parkinson's. He got he had a feeding tube placed. I don't really recommend the feeding tube. This was before I was a doctor, but he was happy. He lived 2 more years. He never ate a thing for 2 years. He didn't eat, but he's an incredibly religious man, so he refused, and he was happy to do it. And so everybody gets to make their own unique decision. And it doesn't mean I'm going to tell you go put a feeding tube in if he or she can't eat. It's going to be, what do you think she would have wanted? And is she living a quality of life? Do you feel like this is acceptable for what she would have wanted? But incredibly unique decision in the end, which is what most of these things are.
Is strength training with weights a plus for managing Parkinson's disease?
I think that's going to also vary from person to person. Yes. I mean, why not? I think it's a great idea. But do you have to? No. And I don't think the studies ever panned out all that well to say if you do this, that, or this, that you're better than if you do that, that, or this, that type of thing. What they really found is if you do the exercise you like, then you're going to keep doing it, which is going to be helpful for you. But sure, I think weights would be perfectly fine. It doesn't have to be heavy weights. Yeah, probably stuff that just maintains muscle mass. So high rep, low weights. That makes sense to me. But I would just go see a physical therapist, see what their recommendations are. I don't usually give the like, yeah, you should be doing this, that, or this. It's more so talk to therapy, regularly stretch. You better be walking at least 4 to 5 days a week for 30 minutes, getting a brisk walk in if you can, that type of thing.
I understand nausea can be a side effect of levodopa. Can anything be done to help with this?
It varies dramatically. Levodopa is by far the most common side effect is upset stomach. If it's right away, you take it within 15 minutes, you get sick and it goes away after about 45 minutes. Yeah, it's probably levodopa induced nausea. Sometimes taking it with food can be helpful because it blunts how much you get. So you theoretically could get less of it, but if you get less and it makes you not sick to your stomach, oftentimes that's worth it. Sometimes adding a medicine, extra carbidopa, can be helpful. It varies. Levodopa nausea is a challenge for the most part, and sometimes it's some of my most challenging patients is trying to get them to tolerate it, but it varies. It's not an answer that I could give you 100%. What would be worth double checking is making sure that you're not too backed up or constipated, or your stomach's not emptying slowly if possible, if you could know that. Because if you're getting backed up and the levodopa sits in your stomach for a while, it's not digesting as well, going into the gut, then yeah, it'll actually cause more nausea. But even sometimes acid reflux can cause nausea too. And so sometimes it's worth doing a stool sample or getting the breath test to make sure you don't have a bacteria in your stomach, because the bacteria will actually cause nausea. Plus, it'll worsen your ability to absorb the medicine. But you have to talk to your specific movement doctor about it. It's very unique again.
How long do you have to take melatonin before it begins to help?
I would probably argue weeks to months, weeks to probably a couple of weeks. It varies. And it's quite frankly only so helpful, to be honest with you. So if it doesn't really work and it clearly doesn't help and you go to the max dose and you gave it a week or you gave it a month or so, stop it. And if sleep gets worse, okay, maybe it was helping. If it doesn't get any worse, well, it wasn't doing anything. It's only so helpful, but I'd give it at least a couple of weeks. I wouldn't say, it didn't work one night or a couple nights, so I'm going to skip it. That's not usually how it works. You got to give it a little bit of time. It's trying to reset your sleep cycle, which is way easier said than done. And there's probably more to it than just, hey, your sleep cycle's deranged. There's a lot of stuff, as I talked about, that just affects the ability of people to fall asleep.
And this is our last question. If a patient has severe OH dropping 80 points standing and takes max dosage of Droxbia, which causes high blood pressure of 185 sitting during the day, is that safe?
Yeah, it's at this point which is the frustrating part of orthostatic hypotension, is to some extent you try to choose between a rock and a hard place. I would probably rather have someone's blood pressure be 180 if it's dropping 80 points, because if it's 140 and it drops 80 points, they're going to easily not get knocked out. No doubt about that. If it's 180, at least we have a little bit of room where it's going to drop to 100 or so. And so, is it safe? That's a relative question, because it's way more dangerous for somebody to stand up and pass out and smash their head than to have high blood pressure. High blood pressure typically we think doesn't kill you right away. High blood pressure is not good for you in the long run because it puts pressure on your brain, on those little vessels, pressure on the heart. But sometimes we say we're going to punt all that stuff and we need to focus on quality of life right now. And what's going to get someone's quality of life better? Well, if we bump up their blood pressure and it allows them to stand up and walk throughout the day so they don't decondition, that's the trade off. But I have patients who refuse to let me do that, and that's okay. That's their decision, as long as they make the decision. But blood pressure is a challenge. And to pretend that we can control it is crazy, because we can't. We give you medicines that lower it, we give you medicines that boost it. And it fluctuates from day to day, moment to moment, depending on what you ate, how much your hydration status is. So unfortunately, yeah, it's a challenging case. Those are the ones that are really hard to deal with, which is really frustrating. But generally, I would say you got to probably pick the dose that keeps somebody functioning and tolerated at that point, because some people will swing 80 points. I've seen a handful of patients like that this year, and it's challenging. We just talk about, hey, here's the risk of high blood pressure, here's the risk of low blood pressure. Most of us decide, hey, I'd rather keep high blood pressure, live to fight another day, than I'm gonna stand up, pass out, hit my head open, because that's an immediate risk.
Okay. Thank you so much, Doctor, for providing us with this presentation. It's been so detail oriented and thorough, so I really appreciate you being a guest here today.
Okay. Well, I hope it was helpful. I hope I answered a lot of questions today. Obviously, most questions really should just go through your doctor. They're going to be the best at it. Most of this was just to kind of give you guys a basic, here's expectations, here's some information. Hopefully that gives you guys more education on it. And then when you talk with your doctor, at least you'll have more information. You can tell them, hey, I thought about this, that, this, that, this. And so if you guide stuff for their appointments, that's exceedingly helpful too, as opposed to them having to kind of guess what's wrong with you. And sometimes Parkinson's folks don't want to share because they don't want to be a burden or something. But whatever. You're welcome to use us as consultants, as resources. And the good ones of us are going to be happy to help you as best as we can.
Thank you. And I also wanted to thank the audience for spending this hour with us here today. I would also like to encourage you to fill out the survey at the end when you exit this webinar. And you are invited to our next webinar, Medicare One-on-One, which will be Wednesday, October 15th from 12 to 1 p.m. Thank you so much and have a great afternoon.
I assume I'm good to go. Okay. Thank you.